So my topic is the anchor base fixation is enough for the massive rotator cuff tear? Because we have seen some of us are using patches and some of us are doing a SCR, but we have to think this question, why this question arises? Because of this paper. Because this is a very good paper from the Johan Ho in the AJSM. Then if the cuff tear size is more than 2 centimeter, there is a 34% re-tear rate or failure rate, and this result is also supported by Chung and Sugaya in their respective paper. They have concluded around 40% re-tear rate if the cuff tear size is more than 2 centimeter. And we know that in our practice, majority cuff belongs to this category, more than 2 centimeter retraction. Mostly they are more than 3 months old. So there are high chances of re-tear rate, and then we think about a balloon and SCR and revision procedure. So how can we reduce this re-tear rate and how to improve healing in primary rotator cuff repair? So then we can't get revision cases. So tension-free repair, large footprint coverage. As Ayappan sir mentioned that you should be doing a very good biological repair, less implantation to avoid implant-related complication, and also in the revision surgeries, different patches to enhance healing, secondary procedures like SS and release, subacromial and decompression, muscle advancement, biceps stenodesis. All these we can use in the first primary surgery, so that's why we can reduce the re-tear rate. So this is my first case. Is a 55 male, history of fall down, come with the left shoulder pain and pseudo paralysis. Active range is 20, 20, 10, and internal rotation is up to the buttocks. Supra-infra is very weak, subscap is good, biceps pain is present. So this MRI image, this is T2 coronal. We can see the large, massive retracted cuff up to the glenoid. Sagittal is very large tear from the anterior cable till the teres minor. Subscap looks good. Around atrophy is around grade 2, supra, and both in infra. So my first ARS question comes, how to proceed in this case? Arthroscopic single row repair, double row with a patch augmentation, or any other option? So around 40% they go with the patch augmentation and single or double row repair. So what I did arthroscopic transosseous double tunnel rotator cuff repair. So this is a small video how I do a double tunnel. So first we'll start with you can see this is a bald head, massive cuff tear. You can clearly see from anterior to posterior humeral head. So this is an anterior tunnel. I use a special jig, special instrumentation for the transosseous repair. So this is a first fiber wire coming out from the tunnel. This is a railroad suture. I pass around 3 or 4 fiber wires on this suture. You can see the different color fiber wires coming out of the first anterior tunnel. So this is a lateral aspect. It's around 2 centimeter below the GT. This is a posterior tunnel.
What is the diameter of the hole that you drill through this jet?
It's around mediolateral 3 centimeter and enteroposterior around 4 centimeter.
No, the diameter.
Diameter of it's around 5 mm.
5 mm.
5 mm, yes,
Roughly
bilateral.
the same
Like
as
you insert
a
an anchor. Yes, peak anchor. Yes.
Roughly the same as an
Roughly the same, yeah. So another 3 suture coming out of the posterior tunnel. So I pass a 6 suture from the 2 tunnel. And now I pass one by one all the sutures from the anterior and from the posterior tunnel. The suture from the anterior tunnel goes from anterior to the posterior, you can see. And from the posterior tunnel, the suture goes towards the anterior also. So it's like a spider web. And at the end, after tying the knot, we can see there is a beautiful coverage of the whole the humeral head footprint till up to the lateral aspect of the GT. You can do a different kind of configuration with this transosseous technique. In this technique, I did a X box double tunnel rotator cuff repair. So it's like a X and double tunnel. So you can see the beautiful coverage. The cuff is coming towards the lateral tunnel. So nice coverage of the all the footprint. Looks a very biological repair. No need of patch.
Clarification, you said this is a massive tear.
Yes, sir.
And we can go into the semantics of definition of a massive tear, but I'm not going to go into that. So you made two tunnels.
Yes, sir.
And you said that following the mobilization, you were able to bring it to the lateral tunnel, which was about 2 centimeters away
From
from below.
Tip of the STT.
So do you not think that you're over-tensioning the repair? And we know that you can have type 2 failure medial to the knots. Have you experienced that at all? And is there a danger of over-tensioning with this technique?
Yes. Sir, we all know that if you tie a knot over the tendon, so there is a type 2 Sugaya failure. So mostly what I do, I tie a 1 or 2 knots on the cuff, and then I mostly tie a knots over the bony bridge area, not over the cuff. So that's how you can prevent the over tensioning of the cuff. And with this kind of suture sliding technique, you can hold at whatever places you want to cuff. So I just put a 2 or 3 knots on the cuff, and rest of the knots I put on the bony area, not on the cuff. So that's why, to prevent a retear rate.
But what you have just suggested is that you're trying to lateralize the edge of the cuff significantly. So inherently that means you are over-tensioning the repair. What I'm asking you is, how do you ensure that you're not over-tensioning your repair?
I think he answered that by tightening the medial knots first, so that he secures the cuff at a certain distance from the
Yeah.
myotendinous junction, and then
after
he ties.
just like a buttressing all the rest of the sutures. No need to pull the rest of the sutures, just buttress. Like we put a plate, buttressing.
Kaushal, I think the fact that the tissue is able to cover the entire GT and come far distal is a property of the available tissue quantity and quality. It's not the
Yeah.
it's not
So-
the technique, right? So
Yeah, so
you were lucky
usually,
here that the tissue was there.
so before the surgery, I always ask a radiologist that how much amount of the length of the tendon is there. At least you need a 15 mm tendon length to repair this kind of with a transosseous technique. So you can cover the whole the GT area.
Dr. Kaushal,
Yes.
please correct me if I'm wrong. So in anchor, what happens is the two threads, two tail come out of two tails are hinged over the anchor. So we have two tails coming out from that particular anchor, so that we can take a 2 bites from that particular thread and take a knot in the medial side. But in this transosseous, the two tails, one tail come from the medial side and one tail
From
is
the
in
lateral.
subdeltoid.
Yes.
So how can we make a suture
Medial
over the
knot.
medial side?
So there's no
It's-
knot on the medial side, is what
Yeah,
you're, yeah.
Correct. So I think my interpretation was that you're tightening the medial side first, but he's raised a valid point. How do you first knot the medial
This
side
is
and
basically
ensure correct
only
tension?
So usually I put a first knot on the tendon side, so that
So
cuff
if
easily
I
comes to
understood
the.
you correctly, the post is towards the tendon side, so
Yes.
the knot comes towards the tendon,
Definitely,
and not
yes.
towards the side of the.
Knots towards the bone side, and then I just rest of the suture I do a buttressing to the cuff towards over the GT.
Okay, my second question is
Yes.
to make the X configuration.
Yes.
So what I know is if you do transosseous, you can make you have to suture two ends together, two tails together. Then how can you make the X configuration?
No. For the X type of configuration, you need a suture. The suture coming from the anterior tunnel, they goes from the anterior to the posterior.
The bite is in
Bite
posterior.
is from the anterior to the
The
posterior.
anterior tunnel exit of the thread goes posterior to in the
okay.
tissue.
Okay, thank you.
Yes.
And I think another advantage is that with this sized hole, I mean, if you are surgically able, you can put as many sutures. I mean,
Yeah.
probably it'll
From
take 4
the
sutures.
from the one pilot hole, you can pass up to the 8 sutures.
Eight, yes.
I passed the 8 suture from
And
the one
greater the
tunnel.
number of fixation points, I think the more secure the repair, regardless of the configuration.
Yes,
isn't it?
definitely.
I think that's excellent because there's no doubt that transosseous is still the gold standard. And with the X that you're creating a brilliant suture bridge. So you actually get the tension band effect and you don't get spot welding. So I think your technique's fantastic and it's probably cheaper than all of us using multiple anchors to create a transosseous equivalent. Well done.
Yes. Thank you. So we have also another case, so we can quickly go through it. Yeah.
Why not? We have 4 minutes, yes.
Okay, yeah. So I want to see a advanced procedure with this. So is the advanced procedure is possible with the transosseous technique? So answer is yes. You can do arthroscopic transosseous biceps SCR, transosseous subscap repair, transosseous lower trapezius transfer, you can do with this transosseous technique. So I will just quickly go through the arthroscopic transosseous biceps SCR technique. So there is a 60 male, history of fall down, right shoulder pain, pseudo paralysis, range is weak, supra infra is weak, subscap is good. So you can see the massive cuff tear, similar to the first case. So in this case, we did an arthroscopic transosseous single tunnel rotator cuff repair plus anterior cable reconstruction with the biceps rerouting. So I use a biceps as a SCR in this case. So how we did it? So you can see the massive cuff. So first I made a groove for the biceps in the center of the humeral head with the bar. And then just a simple pilot hole like we did in a transosseous technique. You can see I made a pilot hole just lateral to the articular cartilage. In the previous cases, I used to do a tunnel more laterally. So that's why one time I faced a problem of suture cut out through the lateral cortex. That is a one complication of this transosseous technique. But nowadays I made a tunnel just lateral to the articular cartilage. So you have a very good bony bridge on the lateral aspect. So you don't end up with the suture cut out. Yes.
PRP के बुलबुले नजर आ रहे हैं.
The growth factor coming out of the tunnel. So this is a jig goes inside the hole. So I just quickly. So this is a drilling.
But
So-
Kaushal, on a lighter note, I've almost never seen PRP coming out of it. All I see is fat, desi ghee coming out of it.
Yeah.
And these days they are getting stem cells from almost anything. I mean,
Yes.
Dr. Mark Hanna reminds me that adipose tissue has more stem cells. I read a paper, a Chinese group has cultured stem cells from urine and they are injecting into rats with knee arthritis. American Journal of Sports Medicine, so.
So these are 6 or 7 sutures coming out of the tunnel, and I pass a one suture from the biceps. So with that I can reroute the biceps towards the center, and then I repair the cuff over the biceps. So I have passed all the sutures from the cuff. You can see the different color of fiber wires, so you don't end up with the suture entanglement.
My only question is, where do you get such colorful sutures from? We get such dull sutures.
Yes, I have a slide for that. So I have made a package of 7 different color of fiber wires I get from the vendors. You can see all the different color of 7 fiber wires.
Wow.
And I open 7 fiber wires in one surgery. You can see the different color of fiber wires. So you don't end up with the suture entanglement. So we have made a custom made package for the different for each surgeries.
Here in this case,
Because there is a massive cuff tear.
this was looking pretty good in the quality and would have healed pretty nicely. Young patient, 51 years.
But
Why sacrifice the biceps in this one? in
But,
case it was-
since last few days in the few months, I am using a biceps rather than cutting it because the biceps has a very good.
why would you cut it at all? If subscap is fine, biceps is good. It's not, and it's just a massive cuff of supra and infra with a good repairability.
Yes.
Why would we even sacrifice biceps at all?
No, nowadays I am not sacrificing it. I just use a biceps to decompress the humeral head. So it has a decompression effect on the humeral head, and over the it, I repair the cuff. So we get a good advantage of the decompression of the head.
As a depressor, you want to use it.
Yes, yes. And there is a free biceps, so you can use it.
Okay.
So that's.
Thanks,
So the
Kaushal. I think this was a
yes.
very eye-opening and it's very clever of you really to use so many sutures.
So
and
these are
do-
last slide, the rotator cuff repair. All we started from the open repair, that is transosseous. So that is a gold standard. Then we switched to the mini open RCR. Then mini open with the suture anchor. Then arthroscopic with the suture anchor, and again arthroscopic with transosseous. So we are going back to the future.
Will a conservative treatment come after this? Well, thank you very much.